Brain stimulation, creating a perfect storm in brain circuits of depressed patients. Electroconvulsive therapy. Failure to respond to a variety of antidepressants, singly or in combination, is a key factor for considering ECT, and may also be utilized in urgent and severely disabling high-risk circumstances such as psychotic, suicidal, or postpartum depression. ECT is the only therapeutic agent for the treatment of depression, with the possible exception of experimental agents like ketamine, scopolamine, and sleep deprivation that is rapid in antidepressant onset, with therapeutic actions that can start even after a single treatment. The mechanism is thought to be related to the probable mobilization of neurotransmitters caused by seizure. Memory loss and social stigma are the primary problems related to ECT. Transcranial magnetic stimulation. It uses a rapid alternating current passing through the small coil placed over the scalp that generates a magnetic field, which in turn induces an electric current in the underlying areas of the brain. It depolarizes the affected cortical neurons, thereby causing nerve impulses to flow out of the underlying brain areas. Presumably, daily stimulation of DLPFC and its circuits to VMPFC and amygdala and the brainstem centers for up to an hour over several weeks causes activation of these circuits. That leads to antidepressant effect by monoamine modulation. No peripheral side effects such as nausea, weight gain, blood pressure changes, or sexual dysfunction is present. Deep brain stimulation. This is an experimental treatment for the most severe form of depression. The stimulation device is a battery-powered pulse generator implanted in the chest wall like a pacemaker, and 1 or 2 leads are tunneled under the scalp and then into the brain. The most common side effects are from the procedure itself. One proposed location for electrodes is the subgenual area of the anterior cingulate cortex of VMPFC. Now let's discuss psychotherapies as epigenetic drugs. Drugs in psychotherapy may have a common neurobiological link, since both can change brain circuits and combining them may be synergistic. Bad memories of childhood trauma may trigger psychiatric disorders by causing unfavorable changes in the brain circuits, and good memories formed during psychotherapy may favorably alter the same brain circuits. The best psychotherapies to combine with drugs, particularly for the treatment of depression, are CBT and interpersonal therapies, which has a 12 to 24 week program that follows progression with a beginning, a middle, and an end. The new trial-based therapy described by De Oliveira is a version of cognitive psychotherapy that is intuitive, readily adapted by psychiatrists, and can even be fun. The patient literally puts his psychiatric symptoms and core beliefs on trial. This idea is based on the universal principle portrayed in Franz Kafka's The Trial, that human beings by their very nature are self-accusatory, and this can lead to confusion, anxiety, and existential suffering. Here, during outpatient psychotherapy, a patient's self-accusations are put on trial as distorted schemas and core beliefs that have been developed about the self by patient's inner prosecutor. Therapy seeks to point out to the patient that his symptoms and sufferings are due to his core beliefs that can be countered by activating their inner defense autonomy, and to see things in a more balanced and realistic way, and thereby relieving symptoms. Combining psychotherapy with antidepressants has the potential of making the entire outcome greater than the sum of its parts, like 1 + 1 becoming 3.